Okay, for the next topic in our chronic neurological disorders, we're going to talk about multiple sclerosis. And again, I'm going to try to keep this as simple as possible. There is a lot going on with MS that is going to be the same as a lot of the other chronic neurological disorders. So we'll look at the things that as a nurse we would expect to do. And for the management and treatment for a client with MS, as well as looking at some of the medications. So MS is going to be a symptomatic disease process that we think of as it's separated in time and space. So it's kind of very Doctor Who-ish. We're looking at lots of wibbly wobbly moving parts here that again are going to be very similar to other chronic neurological conditions that we will talk about. So we need to differentiate, and most of the times that will probably be differentiated for us. Client or the nurse is caring for a client with multiple sclerosis. Which actions are the priority? What medications do you expect? Things like that. So I would say, just from a knowledge base, you will need to understand that this disease is generally characterized by the formation of plaque. That plaque can cause lesions, it can cause inflammation, it can cause scarring, and all of that is around the myelin sheaths. So the mechanism that our body uses to carry the signals from our brains to the rest of our body. Typically speaking, a patient may initially present with paresthesia in the hands that kind of resolves on its own, and then it can be followed by a few months later by this generalized weakness in the lower extremities or visual disturbances, so diplopia, so our double vision. Don't confuse diplopia for our ptosis and our drooping eyelids that we would associate it with more of a myasthenia gravis instead of a multiple sclerosis, and that's one of those tricky things that like to do to you. So with this one, I just kind of expect a double vision. Typically, the onset and duration of the attack can be longer than 24 hours. It can be extensive, especially if we're not doing the things that we're supposed to be doing from a pharmacological standpoint, if we're not taking our medications, or we're suddenly stop taking medications, if we're not still exercising and doing the things to live a healthy lifestyle. We don't know exactly why MS is MS. We think it's a lot of underlying comorbidities, immune factors, environmental factors, genetic associations. But one of the big things that we need to teach our client is that there is no known cure for MS currently. So we're going to characterize, there are keywords that we're looking for, is periods of exacerbations and relapses. All right. So we're going to kind of go through our whole neurological assessment for any new or recurrent neurological symptoms. We know that those signs and symptoms can develop over days or weeks, and they can last 24 to 48 hours, if not longer. So unfortunately, the presentation of MS varies. So we can see clients that have some cognitive changes, while others have ataxia or issues with movement, hemiparesis, paraparesis, depression, and again, we see that visual symptoms. So a lot of this is going to be based upon health and history, getting information from the client, and then we'll look at some of the other diagnostic tests that we can look for, that plaque formation. So kind of what the classic multiple sclerosis expected symptoms are going to include. And we see that it's this laundry list. So we have that sensory loss, that touch, that paresthesia in the upper extremities. We have muscle cramping. It can be secondary to that spasticity, so the ataxia, the hyperreflexia, all these really weird neuro words that just say that the client doesn't have the muscle coordination that they used to have, and we need to promote safety for them. We see we can have issues with bowel bladder, spastic bladder, flaccid bladder. It can also include sexual dysfunction. We can have issues swallowing, rapid eye movements, and something called an intention tremor, which again is going to like mimic the signs and symptoms of what you would see in Parkinson's, except here that tremor is going to happen with voluntary movements. So while I'm at rest, no tremor, and then when I'm moving, I'm going to have that intention tremor. So you're intentionally doing something, you're intentionally having movement that causes that tremor because of the MS. That's going to be very similar to what we're going to talk about with Parkinson's, except with Parkinson's, the tremor is going to be there at rest. So we have to think about this as we're walking through of which disease process is a little bit different. You can have bilateral facial weakness, trigeminal neuralgia, things that mimic the signs and symptoms of Bell's palsy. You can have this facial myokemia, this irregular twitching of the facial muscles, which can mimic kind of your electrolyte disturbances, particularly with sodium, calcium, and potassium. We talked about diplopia, optic neuritis, so we can have this loss of vision in the affected eye or pain with eye movement, heat intolerance, fatigue, which is probably the most common thing, but it's the most common thing in everything, dizziness, decreased concentration, depression, lack of sleep, exertional exhaustion, and then pain. So again, we've talked about the fact that with a lot of these disease processes, it's this process of just controlling the underlying triggers, treating the signs and symptoms, providing comfort, providing rest. So we want to address any possible underlying cause of a relapse, such as an infection or the metabolic disorders we talked about. We're going to provide symptomatic treatment based upon their specific signs and symptoms. So if it's bed rest, or if it's eye patching, or if it's medications, it's pain control, we're going to do those things. Usually, I would expect to administer a short course of corticosteroids. And we'll talk about methylprednisone and prednisone, so IV push or PO. And then finally, that we're going to encourage them to start or implement a rehabilitation program because we want them to regain at least a function of their normal ability to perform ADLs. So just assessing for visual acuity, checking their speech patterns, right? Do they become fatigued with talking, difficulty swallowing? We talked about activity intolerance. Because you have issues with paresthesia, you can have issues with skin integrity. We want to make sure that we're encouraging them to drink fluids or give them lots of fluids to help prevent further infections, so UTIs. We may have to assist them with bladder and bowel elimination. We may have to help them communicate because of the dysarthria, so we can do that via communication board. We can use eye patches. Typically, we'd alternate every couple of hours with your eye patches. So if I have the eye patch on my left eye, I would have to teach them also to scan the room. So just basically, you have to turn your head to look at things. Encourage exercise and stretch the involved muscles because we are going to have that rigidity. We're going to have that loss of muscle strength, muscle coordination. So while we always encourage exercise, we also want to make sure that we're promoting periods of rest. Maintain a safe home and hospital environment. So we're going to remove clutter, going to remove things with sharp edges, making sure we teach them to walk with a wide base to help prevent falls. Maybe they need an assistive device, a cane, different things like that. We're going to teach them the importance of making sure that either we are turning them or they are self-turning, that we are inspecting our skin for any issues. And then, unfortunately, we know that post-birth women are going to have a worsening of the symptoms of MS. So we have to do a lot of patient teaching for our young women who are now diagnosed with MS. And we're going to talk about that with medications as well. I don't care that you know the doses, but I do care that you know that usually we expect methylprednisone or prednisone. And then you know that with any of those corticosteroids that you have this huge risk of side effects for these medications. And corticosteroids, we know that they can decrease how well our body fights infection. Well, that could be an exacerbating factor in this exacerbation of MS. Make sure that we are tapering them off of the medications as prescribed. Make sure we're assessing their blood glucose. We know that it's going to have an effect on that. If you have a poor tolerance to your corticos, you can do Plex, a plasma exchange, so that's going to help take away some of the antibodies. I really haven't seen that a whole lot anywhere, but it is an alternative. We can expect those disease modulating medications. So you may hear them called DMTs, disease modifying therapies. Just generally your interferons, your IVIG, that's going to help prevent the body from attacking itself. We want to encourage them to use some of the muscle relaxants. Tizanidine, baclofen are probably most common. We can also use a diazepam. Azathioprine and cyclosporine are immunosuppressants. Those are the most important things that we're going to have. But again, because they are immunosuppressants, you are going to have increased risk for infection and bleeding. And those medications are not for pregnant folks. Our anticonvulsants, carbamazepine is going to help with paresthesia. Our stool softeners to help with the bowel issues. Our medications to help with bladder dysfunction. So it's propanvaline, and that's going to help you with the bladder dysfunction. And then we see a beta blocker, propranolol or clonazepam, and that's going to help with that kind of spasticity, the tremors. Nutrition, we're talking about mega vitamins, low fat, gluten-free. A lot of our folks have allergies to gluten, it turns out. We want to teach them to eat healthy, high protein diet, high fiber to help prevent constipation. Diagnostic exams, I would say mostly what we're probably going to be going off of is the H&P. And then as we progress, I would say MRIs/CT scans. They're going to help identify plaque or lesions to the brain or spinal cord that are going to cause those exacerbations. We can do a lumbar puncture. So we would expect that that CSF that we drain would have high levels of protein, elevated IVIG levels. So we know, we've talked about LPs, the client's spinal cord needs to be stretched either through the cannonball position or while leaning over a table. And you can also do an evoked potential study. And usually evoked potentials are going to show a deterioration, a slowed impulse of the nerve signals. And I can count on one hand how many times I've actually even seen evoked potential studies done on a client. Because again, most importantly thing is probably your health, history, underlying comorbidities, and then if we see things on the MRI or lumbar puncture. Lots of issues with our disease modifying therapies, and we go through the laundry list here. I'm just going to say if you see a MAB, a MOD, or MIDS, so we got our M's, right, that you should know that you have this increased risk, especially, again, for our women of childbearing age. A lot of these medications can have teratogenic effects. You can see the list there, but you need to know that those MABs, MODs, and MIDs have really bad side effects. We can think about seizure precautions because, again, this is the issue with your nervous system's electrical signals. We want to take steps to promote fall prevention. So our hourly rounding, our fall mats, our bed alarms, all those things that we would expect. Help our client with coping strategies. This is a lifelong disease process. We want to encourage those healthy behaviors because now they're going to be at increased risk for all the other neurological disorders that accompany that, all the acute ones like stroke, and obviously bodily injury, things like that for falls, airway, breathing, circulation because of the airway issues. And that is MS. Very short, very brief. Again, we're monitoring airways. We're promoting patient safety. It's a lifelong disease process. Just from a basic nursing standpoint, I would make sure that we understood the importance of corticosteroids because of the inflammatory process, and making sure that you are able to perform health promotion activities for your client.